High costs of health care, hospital readmissions. Why do patients keep coming back? The United States is the leader in many areas of the world's economy and has the highest figures in annual expenditures in healthcare compared to any nation. Why? Although there may be many contributing factors, I will be focusing on hospital readmissions. Identifying and understanding the cause. Data from the Healthcare Cost Utilization Project states healthcare reform has pinpointed hospital readmissions as a key area for improving care coordination and achieving potential savings. A readmission is an additional or repeat hospital admission within 30 days following an original admission, regardless of the reason, and can negatively impact patient outcomes and costs associated with care. According to HCUP, the top 3 leading diagnoses of hospital readmissions in each payer system were as follows: Medicare, congestive heart failure, septicemia, pneumonia; Medicaid, mood disorders, schizophrenia, diabetes; and privately insured, maintenance chemotherapy, mood disorders, and complications of surgical medical care. The results in hospital costs were as follows: Medicare, $4.3 billion, Medicaid, $839 million, and privately insured, $785 million. A study published in the Department of Health and Human Services Public Access entitled "Why Do Patients Keep Coming Back? Results of a Readmitted Patient Survey" conducted an observational study that used existing administrative data from various hospitals of different classifications and bed capacities. About 2/3 of the patients that were discharged reported good discharge experiences, yet were still readmitted within the 30 days. Although the exact causes for these readmissions were unknown, it was believed to be related to poor coordination of care after discharge or poor follow-up care. These readmissions resulted in $12 to $17 billion spent annually. Greater than 74% reported that they understood the instructions for self-care, medications, when to contact their physician, the ability to get their prescriptions filled, and having transportation for follow care. These patients believed themselves prepared for discharge. So what about the 26% that were not prepared for discharge? These patients tend to be of male gender and patients of low socioeconomic backgrounds. These patients were less likely to report that they had a follow-up appointment with their doctor scheduled, less likely to express understanding of self-care or discuss concerns with the hospital or doctor's office, and were less likely to get their prescriptions filled. Programs developed to reduce costs. In 2012, the Hospital Readmission Reduction Program was established through the Affordable Care Act as not only a means to create a quality measure, but as a way to alter the cost curve of healthcare. Hospitals were evaluated on their 30-day readmission rates of acute myocardial infarction, heart failure, and pneumonia, and then assessed penalty fees if they had higher than expected readmissions for these diagnoses. Based on data from 2008 to 2011, hospitals were assessed penalty fees of over $750 million in a 3-year period. In the first year, 2,213 hospitals were fined $280 million. This figure is actually $10 million less than the HRRP expected. The second year, 2,225 hospitals were fined $227 million, and in the third year, 2,610 hospitals received fines for hospital readmissions. The hospitals that were affected were large hospitals, teaching hospitals, and safety net hospitals that serve the low-income, underprivileged, and vulnerable populations. Interventions. What is being done to remedy this situation? For the first time, Medicare is shifting its goals from fee-for-service to a value-based payment system, and by the year 2018, plans to have 90% of its fee-for-service payments tied to quality or value. Examples of facilities that are in the progress of making a successful change in lowering costs and improving quality of care is Kaiser Permanente's Transitional Care Programs and Bundling Elements, and Colorado's Accountable Care Collaborative, which pilots healthcare payments and delivery reform for Medicaid. Call to action. What can we do as individual healthcare providers? On an individual basis, we may need to address these groups that have the highest readmission rates. Staff may need to address discharge instructions, concerns, ensure that transportation needs and ability to fill prescription needs are met. If not, refer these patients to social service or programs that can assist these patients so that their care at home beyond discharge is satisfactory, thus improving the quality of patient outcomes, reducing the rates of hospital readmissions, and thus reducing the overall cost of healthcare. Thank you.